Dr. Chris Rogers is our next speaker. It's interesting. I met Chris a few years ago. I was teaching at another conference, and someone came up to me, and I swear I thought he was a resident or something because of how young he looks. But he came up to me, and we started this relationship, and he's an absolutely amazing person. Although he does not seem to age, he has more than 20 years of clinical experience. He's one of the world's leading experts in the field of orthopedic regenerative medicine, and he specializes in non-surgical treatment of various different musculoskeletal conditions. He first developed his interest in sports medicine back in 1984 when he was working as an athletic trainer at the University of California, and he has held many titles: Associate Clinical Professor at the University of California, San Diego, Department of Orthopedics. He has been a team doc. He's worked with various different team sports. He, in 2009, started advanced regenerative medicine training, and he has done dozens of courses and taught at dozens of courses across the nation, including the Academy of Regenerative Practices, Regenerative Medicine Training Institute, IOF, and the Orthobiologics Institute. Dr. Rogers has published and lectured extensively throughout the nation, and he is on the board of directors for the American Academy of Board of Regenerative Medicine, and he created the San Diego Orthobiologics Medical Group in 2016. Today he's going to be talking about what constitutes evidence-based medicine and who should decide. Dr. Chris Rogers.
Yes, hello. Thank you. You've made it to the end of the program. Congratulations. Thank you, Dr. Malenga, for inviting me once again to speak at this awesome conference. I've thoroughly enjoyed each of your presentations and really excited about where we're going as a group. I was asked to review evidence-based medicine. What is evidence-based medicine? Who should decide? Even though this is a study on evidence-based medicine, it will be the least evidence-based lecture you will probably hear during these 2 days. So give your brains a chance to expand a little bit and relax. We're not going to go through a ton of really detailed slides. What I wanted to do instead was offer a historical perspective of what evidence-based medicine was intended to be, and then just sort of give you my bias and my opinion about my concerns about the narrative around evidence-based medicine, and what I think maybe we should all be focusing on as a group. So my disclosures, I do believe in data. I'm participating in some clinical trials with a personalized stem cell who's a sponsor for FDA-approved clinical trials. I also believe in collecting data. We have a data biologicist registry with Dr. Malenga and Dr. Bowen. I like teaching, so I'm a consultant with Lipogems, and my biggest bias is that I am a private practice physician that believes in using evidence-based medicine with our patients to help them make informed medical decisions. So my biases will show through in this talk. So many of you recognize the music as I came in. That was intentional, of course. I'm a huge fan of John Williams, amazing composer, conductor, who created the soundtracks to many of your favorite movies, including all of the Star Wars saga movies, including this one. I have it up here because I thought there were some interesting parallels between our universe of cell-based therapy and this galaxy far, far away. As you know, the first movie that came out was actually wasn't called A New Hope. It was called Star Wars, but then later was renamed A New Hope, just like MSCs were originally stem cells and became signaling cells. Some interesting parallels. And when stem cell first came out, we were all excited, and the cellular biologists were making all these fantastic discoveries, and we had this new hope that we would be able to treat conditions that were previously untreatable, to cure diseases that were previously incurable. And so we've gone through this long period of time where the science has advanced, and we heard Dr. Kaplan yesterday say that it feels like we are at the end of the beginning. So it feels like that for me as well. We're at the end of the first movie, and now we're moving to the second movie, which some people actually like better than the first, which is The Empire Strikes Back. And what I mean by that is we're moving into translational medicine, and there are lots of challenges to translational medicines, and there are a lot of special interests that maybe are critical of us translating the science into a clinical practice. And this is what evidence-based medicine is actually all about. So Jerry actually asked me to give this talk about evidence-based medicine when Google made this announcement last year that they were announcing a new healthcare and medicines policy that banned advertising on the Google platform. And they didn't want us advertising unproven or experimental medical techniques. And originally, the belief was that the intention was we're going after these bad actors who are making unsubstantiated claims, committing fraud, essentially. And so it seemed like, well, yay, Google, you're doing the right thing. So if you look at their healthcare and medicines policy, they again and again say we want to prohibit advertising for speculative or experimental medical treatments. And this policy is global. This is a global policy, so wide-reaching impact. So they're really establishing a strong narrative here that they hold this position that speculative experimental treatments should not be advertised. But then they go on to explain what kinds of treatments they're talking about, and they talk about stem cell therapy, but they talk about other cell-based therapies, which we've been talking about for the past couple of days, and platelet-rich plasma, which, as you know, has some actually very interesting evidence to support it. So then I looked in a little bit deeper and I thought, well, maybe it's not such a virtuous position they're taking. Why are they giving up tens of millions of dollars in digital ad revenue? Well, if you take a look, Google's actually owned, and by the way, this is just my opinion, not the opinion of IOF, but Google is owned by Alphabet, and Alphabet just happens to own a life sciences company called Coleco, which just happens to have a $3 billion relationship with this stem cell company called AbbVie. So it's maybe not entirely a virtuous move on their behalf. I have no evidence to support this accusation, but it's just a little curious. In addition, the International Society for Stem Cell Research, which is composed mostly of academic-based scientists, PhD types typically. Some of them are involved in translational medicine, but they have put forward statements as well that they applaud this effort that Google is banning these unproven therapies. And the president of the association goes on to say this is a much needed welcome step to curb the marketing of unproven stem cell therapies. So you keep seeing these words used over and over again. If you look at the guidelines from the Stem Cell Research and Clinical Translation, again, there's a warning there of marketing unproven stem cell-based interventions. So we get into this situation where they're condemning this clinical translation. And to me, it feels like it's black and white, right? We're talking about proven versus unproven. We're talking about validated versus not validated. We're talking about established versus speculative. And Chris Santano talks about this in a blog, this false dichotomy. The world is obviously much more complicated. Again, keeping with the Star Wars motif, we have the Force, which maybe represents the truth of all things in the known universe. And you have the light side and the dark side. And on the light side, you have the virtuous who are pursuing the ultimate truth with randomized clinical trials and level 1 evidence. And really, nobody should be participating in any of this activity until we have that data. And then you have the dark side, which condemns those that might entertain clinical translation too early. And there certainly are individuals that do that. But the narrative is becoming a little bit too black and white for me in some of these groups. So those of us that are clinicians, let me see your hands, people that treat patients every day, here you are. So we live in the real world. We treat patients every day. We use the evidence to help our patients make good decisions. We live in the gray zone, and so I'm going to include you all in the Rebel Alliance, because you are rebels. And every day we are using the evidence as best we can for our patients. Yeah, we do some strange things out in California. So now, the AMA did voice concern about the Google action, that although they applaud the addressing the seriousness of the issue, they also want Google to make public the process that it will be used to vet advertisements and what evidentiary standard will they use to determine what's appropriate and what's inappropriate. So I think that would be a positive thing if that actually happens. So do you practice evidence-based medicine? Well, what is evidence? The available body of facts or information indicating whether a belief is true or false. Why do we need evidence? Well, we live in an uncertain world. We don't like uncertainty as human beings, so we want the evidence to help us maybe predict whether or not a treatment will be effective, what possible risks and benefits might I incur. Prior to data, we had dogma. And dogma comes from the School of Medicine in ancient Greece and Rome, and it was based on the philosophical opinion of Hippocrates. And so Hippocrates is a pretty smart person, so let's just do what he does. And that actually continued for 2,000 years, particularly in bloodletting. So bloodletting's been around for 2,000 years. You know, today we're debating whether it should be leukocyte rich, leukocyte poor. Well, back then, it was all bad. White cells, red cells, platelets, they all got to go. Nothing 500 liters of bloodletting can't cure. And so it goes back, actually before Hippocrates, it goes back, there's actually instruments found in Egyptian burial sites. And then as recent as the 19th century in Europe, bloodletting was a prominent activity. Dr. Clutterbuck, in his lectures on bloodletting, talks about, in short, bloodletting is a remedy which, when judiciously employed, is hardly possible to estimate too highly. And look at all the things it can treat. It looks like some of the stem cell clinic websites that I've looked at. Now, if surgery is too much of an invasive procedure for you, we can do little bloodletting procedures using leeches. And leeches actually was a huge industry. I didn't know this until I started reviewing some of the historical evidence, but this was used as an alternative to bloodletting. And in Ireland, it became so popular that one species of leech actually became extinct, and then they had to start importing the leeches from England. In 1833, this is a good Trivial Pursuit question, France imported more than 42 million leeches. And those leeches were eventually exhausted from France and England, and then they had to create this international shipping industry, getting leeches from all over the world. I think it's also interesting to note that the industry debated which leeches were best. You could just imagine all the exhibitors out, in the hall there saying, no, you have to get the green leech or the English leech or the spotted leech. So I don't know how much data there was on any of that back then. They had adverse events. Some of the leeches were poisonous. Didn't work out so well. And then, interestingly, the poor did not get access to leeches because the treatment was too expensive. So I thought the parallels with what we're talking about today were pretty amusing. So then comes Dr. Pierre Charles Alexandre Louis, who is a French physician who in the 1800s decides, hey, let's collect some data. So he has this numerical method where he's going to actually assess the effectiveness of therapies. And he collected data from patients who had pneumonia, and back then the main treatment for pneumonia was bloodletting. And he collected data and he showed it doesn't work. And basically, he published his findings in the American Journal of Medical Sciences and met, surprisingly, some resistance from his colleagues who said they were not prepared to discard this therapy because it was validated by tradition and their own experience. And by the way, why would we believe somebody else's data? That makes no sense. So then fast forward to the 1900s, Dr. Sackett, who also is considered one of the fathers of evidence-based medicine, founded the first department of clinical epidemiology and challenged this notion that we have always done it this way and said instead, no, maybe we should collect data. So he published a 25-part series of articles called The User's Guide to the Medical Literature, and that became very popular. And he defined evidence-based medicine as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of an individual patient. And this is the take-home message. Evidence-based medicine takes place between a physician and a patient. He also said, half of what you learn in medical school is dead wrong. I love that quote. Okay, so there's different levels of evidence, of course. We're all familiar with this. We have case series, we have randomized clinical trials, and then living at the very top of the pyramid will be your systematic reviews and your meta-analyses. And then you can assess the level of evidence for a given treatment based on the quality of the studies that support or don't support a given treatment option. So we want level 1 evidence with systematic reviews and meta-analyses, but as Dr. Buford mentioned, a lot of our orthopedic evidence is really this level 3 evidence where we just have some well-designed controlled trials without randomization. So obviously we have a lot more work to do. Dr. Cochrane, Archibald Cochrane, also thought it was a real crime that we were not using the data to help make clinical decisions. He said it is surely a criticism of our profession that we have not organized a critical summary. So that inspired the Cochrane collaboration, which, as you're familiar, creates systematic reviews. And you can see that graph, how things just took off after 1993. We have all these systematic reviews for all areas of medicine. And then this just reinforces that the evidence-based medicine, the original intention was to use, again, between individual physician and patient, using these systematic reviews. So evidence-based medicine involves the three pillars, the scientific evidence, the published literature. It does take into consideration the experience of the physician, and it takes into consideration the patient's goals and priorities. And perhaps that might be the most important pillar. And those of you that are in the Rebel Alliance now will practice and have practiced evidence-based medicine, keeping in mind these three pillars of evidence. One is not greater than the other. There was a conference held in 2005 where healthcare providers and teachers and developers decided how should we actually implement evidence-based medicine, basically formulate a question, find the evidence, critically appraise the evidence, apply the evidence to that patient treatment, and then evaluate the outcome. BMJ hailed evidence-based medicine as one of the milestones in medical history since the 1840s, right up there with penicillin and vaccinations. So we really like evidence-based medicine, but not so quick. There are pitfalls to our evidence. There are limitations, as we all know, to randomized controlled trials. Randomized controlled trials ask, does this work? It doesn't necessarily ask, why does it work well in some people, but not others? We narrowly define the context, so it's reductionistic by design, and therefore not always translatable to real-world contexts. In addition, studies are rarely repeated. There's this race to be the first person to study something, and then that study is rarely repeated because it loses some of its sexiness. And those studies should be repeated in new contexts to see if the original findings hold up. Well-designed studies, as you know, are expensive and time-consuming, and often they're funded by industry, which introduces some bias. And many randomized controlled trials are just poorly designed, conducted, analyzed, or reported on. And so Dr. Malenga and some others commented in the American Journal of Sports Medicine when this paper that you've all read was published, The Efficacy of Platelet-Rich Plasma for Interstitial Supraspinatus Tears, a level 1 evidence study, well-designed study actually, but they inadequately described their PRP. You heard about this yesterday. And we remind them that there's actually a classification system that you can use. But then they respond by saying, well, the reality of clinical research is that it takes a lot of time, and by the time it gets published, the data may be outdated or inadequate. And furthermore, the literature suggests that PRP doesn't really work for rotator cuff tears anyway. They I'll go back. And then they go on to cite a study that actually proves the exact opposite of the claim they just make. Let me just zip right through this again. So context does matter, how you look at the problem and how you measure the problem. I always encourage us to read the methods section. So this is a study where orthopedic surgeons were asked to see whether or not they could predict who would do well with a meniscus tear with either surgical care or non-surgical care. And they made 3,800 predictions, and basically their results indicated that orthopedic surgeons correctly predicted the outcome 50% of the time, which is a coin toss, right? And they also said experienced knee surgeons were not necessarily any better than beginning knee surgeons. Their prediction capability was about the same. But if you look at the methods section, how was this study conducted? It was an online survey. So orthopedic surgeons were emailed 20 cases that looked like this, where you had the patient history and the physical exam findings, the MRI summarized, the X-ray summarized, and then they were asked, what do you think, meniscectomy or physical therapy? That doesn't really represent what we do in clinical practice. Those physicians didn't have the opportunity to do a physical exam or take a history or actually look at the MRI images. So context matters. There are limitations of meta-analyses and systematic review, and I've listed them here, but in the interest of time, I'm going to move on to our next slide. But essentially, we give this weighty value to evidence, but we have to also critically analyze the evidence. Going back to the Cochrane collaboration, 11,000 systematic reviews were reviewed, and half of them showed no benefit or harm. Again, a coin toss. And 96% of the reviews said, you know what, we really need more research. So those reviews are limited in their value. The last PRP Cochrane review was in 2014. So we rely on this data, and the data is important. We should continue to make these efforts. But it doesn't replace evidence-based medicine. Evidence-based medicine, in that narrative that I was alluding to earlier, is evolving or devolving into healthcare, evidence-based healthcare policy. And evidence-based healthcare policy is not necessarily living on these three pillars. Matter of fact, the physician's experience is usually discredited. The patient's goals are often discredited, and they're replaced by the financial and political goals of the healthcare policymakers. So this is not evidence-based medicine. A Cochrane board member was kicked out of the Cochrane board because he was outspoken. He was concerned that the Cochrane collaboration was getting a little bit too chummy with the pharmaceutical industry. So he was kicked out. And then 4 of his colleagues elected to resign in protest as well. Let me just move on to the next slide because I'm watching our timer here. Who remembers the AHCPR guidelines that came out in the 90s? Yep, we're old enough to remember that. So it was a governmental agency that conducted health service research, and they produced this guideline for acute low back pain that all of us read, and included that there was no evidence to support spinal fusion, and that, in fact, there were a lot of complications from spinal fusion. So North American Spine Society didn't like that too much, so they created an ad hoc committee which attacked the AHCPR guidelines, published a letter in the Spine Journal, and basically claimed that AHCPR, this government agency, had wasted taxpayer dollars conducting this review. And then one NASP member took it a little step further. One of his patients was a Republican representative and attempted to get the House to defund the agency. So at this point, you may think I'm anti-data or anti-evidence or anti-healthcare policy. But I'm really just saying that the art of medicine is and always will be an art. And although we need the evidence to guide us, it's not a simple paint by numbers. And instead, I would offer that the evidence is a tool that we can use properly or improperly, and it gets applied to a given patient by us as a craftsperson. So with the remaining 8 minutes that I have, I just want to show you some anecdotal stories. We don't talk about anecdotal evidence too much at these talks, but I'm going to take the liberty of doing that here because they demonstrate how evidence-based medicine actually plays out in our practice. And all of you can think of 300 patients that would also apply. So first I want to talk about scientific evidence. So those of you that like to play golf may know this guy. He's on the Golf Channel. Dave is the reason I got into regenerative medicine. In late 2008, he approached me and he said, I have tennis elbow and I want PRP. Because he works with a lot of professional golfers, he knew what PRP was. He was going to Europe, learning about it. So I treated him, but before I did that, I reviewed the medical literature by doing a lit search, and in 2008, there wasn't a whole lot. We had Dr. Mishra's well-reported study, which was a clinical case series, which showed safety and efficacy. And then I called my smart friends at Mayo Clinic and other institutions, and I said, what do you guys think? And they said, well, we think there's something to this PRP. So I treated my friend, not knowing what I was doing at that point, but he did very well. You can see his before and after ultrasound. You guys have seen these before, where the tendon shows increased hyperechogenic changes, and you see decrease in the swelling of the tendon. And I just saw him not too long ago, 12-year follow-up. He's still doing fine. So that's reassuring. And then more recently, if you do a literature review, I say, well, actually, there's quite a good bit of evidence. So we were fortunately on the right side of that argument, even though we didn't really have the evidence, but we used what we had available at that time, and it worked out for Dave. The other pillar, physician's experience. So this is a case where I had a 42-year-old elementary school teacher who fell down a flight of stairs on a bus when she was on a field trip, injured her sacroiliac joint ligaments, And I managed her with standard of care, medications, bracing, physical therapy. And she did reasonably well, but she'd have these frequent recurrent episodes of disability where she'd miss 2 or 3 weeks of work because of her condition. Well, I did a lit review, and back then, no data for PRP or any other biologic for sacroiliac joint ligament injuries. But I had treated a number of patients. And I do track my data. This is a pitch for data biologics. But I didn't have data biologics back then. I had an Excel spreadsheet. But I was tracking data. Actually, my first patient was my wife. So I have really good data on her. And she had a similar injury. So what do? I called the work comp utilization review doc. Well, that was a waste of time, right? So I said, look, I've been treating sacroiliac joint ligaments for a long time. Been doing PRP now for a while. To me, it makes sense. Worth trying. Seems safe. Well, I, of course, got denied. So I told her I'd treat her at my cost, and I provided informed consent. I said, look, there's really nothing published in the literature, but I have some experience. And of course, I injected her ligaments under ultrasound guidance, and we did some more rehab. And since 2015, she's been able to return to work without any recurrent episodes of disability. So that's the case where my experience actually guided my treatment, and I'm sure you guys do this every day of the week. But this is evidence-based medicine. Nowadays, there are papers that have been published on treating sacroiliac joint ligaments with PRP. They've been very effective, including this one that compared PRP to prolotherapy and showed reasonably good improvement with a variety of different metrics. And then with this last patient, we have this patient, the N of 1, which healthcare policy will never address, and randomized clinical trials will never address. And yet you're going to see this patient again and again. Well, you may not see this patient. This is my patient. This is Greta. She's a 65-year-old female pole artist. She is not a pole dancer. She's a pole artist. It's different. And she's a 4-time world masters champion in her event. And she presented with very severe hip osteoarthritis. And I treated her for a number of years unsuccessfully with physical therapy, steroid injections, a variety of other things. And her goal was, I just want to compete one more time. Well, this is her x-ray. It's a bad hip. So I reviewed all the risks and benefits of all the different treatment options. I said, I recommend hip replacement. And she told me, I don't want hip replacement. I'm not ready for it yet. So we looked at a variety of the biologic options, and of course, not promising that I would improve that hip, but maybe improve the symptoms of that hip OA. We talked about BMAC, and after about 4 visits of me meeting with her, telling her she needs a hip replacement, and her beating me down, we moved forward. You heard about the Delphi panel. A lot of times if we don't have data, we have consensus. So if we have physicians who understand the data, we can maybe come to consensus, but I'm just, for the interest of time, I'm going to go through this. But basically, we all agreed, the physicians, we agreed that we should, document the candidacy grade. We should provide informed consent to our patient. It should be done by a physician. It should be done under image guidance. We should track outcomes in a registry. And we should submit results to a peer-reviewed journal. And that's how we handle these types of cases. And this is Greta. After her BMAC injection to her left hip. She's very flexible, as you can see. She has no pain. She was able to compete for 3 more years after this treatment. I did do 1 or 2 PRP booster shots, but other than that, no other treatment other than our usual rehab program. And then in 2019, just last year, she did consent finally to a hip replacement because it progressed. But in those 3 years, she was able to compete and train without pain, and she won 3 more world championships. And I just wanted to share with you this video. This shows the last 30 seconds of her 7-minute routine on a pole when she won her most recent championship. She's 68 years old at this point. Greta's the type of person that makes you want to come to work every day and do your best. And we use the best evidence to help her make a good decision. So evidence-based medicine helps us decide how to do things right often, but it's also important to know how to do the right thing at the right time. At the right time. So for those of you that like to teach. For those of you who like to learn. For those of you who like to do research, please do research and share your results with all of us. And thank you very much for your attention.